Fraser, thank you so much for taking the time today.
Dr. Bubbs, it's awesome to be here with you on this show. Thank you.
Well, listen, I'd love to kick things off here by you telling folks a little bit more about your background and your journey into your current position.
Well, I'm a naturopathic physician. I also have a very long experience in naturopathic education. So I graduated from Canadian College of Naturopathic Medicine in 1997 and was a clinician there and in private practice for quite a few years, having done a residency with Paul Saunders. And over time, I found that I also enjoyed teaching in and outside of the clinic and became dean there at one point. And then for the last 15 years, I've been in Illinois in the Chicago area with National University of Health Sciences, where we have a naturopathic medicine program.
Incredible. Well, listen, Doc, I'm looking forward to really diving into talking about cardiovascular disease and some of the more novel biomarkers, as well as even flushing out the standard, panels and interventions that clients go through, and if practitioners are listening in, their clients are experiencing. But if we start with cardiovascular disease, I mean, this is the leading cause of mortality in the U.S., Canada, around the world, and so to kick off the conversation here, amongst the population, who is at most risk of cardiovascular disease?
Well, it's certainly a disease that is more prevalent in the elderly or older population. So anybody over the age of 50, anybody over the age of 80, it's very prevalent. So you're looking, say, in a country like the United States, about 500,000 deaths, say, from cardiovascular disease per year. And it's kind of similar breakdown per population
Mm-hmm.
in other industrialized countries. Um, there's some breakdown by genetically or by ethnicity, allowing for the fact that those are
Mm-hmm.
generalizations, those are lumping people together, but there are ways in which that can be meaningful. So with heart disease, Hispanic and non-Hispanic whites tend to be a little higher than other groups as so
Mm-hmm.
described. And then in stroke, African Americans, say in my context here,
Mm-hmm.
um, and Hispanics somewhat tend to be a little bit higher as well. The thing I'd like to emphasize, though, is these are typically phenomenon that are years in the making.
Gotcha. And when we look at different populations, if we explore this a little bit more, and again, clients listening in or practitioners listening in, what are some of the risk factors if someone's in your office or in their doctor's office around increased risk for cardiovascular disease, and some of the modifiable risk factors if we talk about those?
Those are the really important things to zero in on. And certainly LDL, which the medical, kind of allopathic or standard medical profession really banks on as their number one target for therapy, that is an exceedingly important factor just because of the massive weight of evidence linking LDL levels with increased chances of cardiovascular disease. I have other things to say about that, but it is truly a major risk factor. Um, but so is diabetes, and that is a very serious problem. The Centers for Disease Control predicts that by 2040, 2050, one in three US adults will have diabetes.
Wow.
And that is, incredible to think. We know that it's telephonic research, I think, or survey research, but about a third of the US population is obese if we take body mass index of 30, which,
General
usually,
population, not a bad marker, right?
yeah, right. There's people with high lean muscle mass and great strength that maybe have BMIs higher than the guidelines as such, but in the 30s, people usually have a problem, and that is going to be the big one. High blood pressure, smoking, still in 2020,
Yeah, for sure.
smoking. It's interesting because in the tables of or various comparative charts about risk, obesity is still considered a minor risk factor, and that is interesting. That's scientifically interesting, and minor doesn't mean trivial. It just means it's not as tightly or consistently correlated with cardiovascular disease as something like smoking. But it also, points to the fact that there could be differences in people with BMIs of 30.
Absolutely.
There could be behavioral differences, and so that has always struck me. It's not a reason to be obese, and we see people get, their diet and their exercise or house in order, or the morbidly obese go through bariatric surgery and completely change their metabolism, and then their heart disease risk and their diabetes risk plummets. So it's no trivial matter, but it's interesting that that one stands aside as maybe not as absolute.
Yeah, it is. I mean, it's so interesting, isn't it, that, as you mentioned, type 2 diabetes being such a strong predictor of risk and events, and you think that would dovetail as well with obesity, but there's some nuance there. And if maybe we circle back to that standard lipid panel that clients are getting when they go to the doctor, and you mentioned LDL, and I'd like to jump in there in a minute, but let's even start with total cholesterol, because that was traditionally the marker that's used to assess cardiovascular disease risk. We see that half of the patients who experience events actually have cholesterol levels that are consistent with the guidelines. So today, is total cholesterol on its own a reliable predictor of cardiovascular disease?
On its own, I think it's unreliable. I think it's like that strange noise that your car makes, right? It could be
Nice.
something that
Could be
isn't
anything.
going to cost you 1,000. It could be anything, you know. Hopefully, you've got an honest mechanic,
Exactly.
but but sometimes it is. So it's unwise to ignore, and that's how I see LDL these days. That it's unwise to ignore it, and it's a fascinating area because it seems like the very high LDL levels in people with strong family history, and then one or two other risk factors, uh, is a harbinger. Is indicating, yeah, in 10 years or 15 years they're going to have heart disease. But when we get out of that upper strata of risk, when we get out of the sicker patients or the patients with more, you know, factors weighing them down health wise, LDL becomes much more fluid type of projection. And if you ask any cardiologist about that, and they're looking at doing the, in a utilitarian fashion, doing the maximum good,
Hmm.
they're going to say, hey, just take the statin and pound that LDL down. It's the LDL, stupid, that
Yeah,
kind
yeah,
of
for
thing.
sure.
And but it's not that simple a story. So it's worth heeding, but by itself, it really fails. As you say, a lot of people with guidelines have within guidelines can still have heart attacks, and it it falls short in terms of predicting things. I believe by itself.
Yeah, I mean, it's interesting because the narrative has obviously shifted from total cholesterol to LDL, and as you mentioned, there's still a good weight of evidence showing that the higher levels are going to be predictive of cardiovascular events, but we do get these individuals who will have higher total cholesterol, have higher LDL, and all other markers are seemingly in good standing order. And I think that's where it gets a little bit, you know, confusing, if you will, from a practical standpoint, because if, do we then do, as you mentioned, just hammer down LDL with a medication despite any other risk factors, or is there potentially more going on? And this maybe, leads into the conversation around other markers. And before we even talk about markers around inflammation, what about things like, even ApoB, ApoA, some of these markers that I often see not even run before we're giving out medications as well. Should those always be run as well as part of a panel if someone is indeed going to be potentially medicated?
Uh, I don't know that always some people are so obviously
True.
high risk. It's okay to go ahead. I think it's not run enough. And so, for instance, someone who is within guidelines, but they have a family history, instead of making the assumption that, well, hey, we got these numbers looking good, and even though both your parents had heart disease by the time they were 60, you know, you're good according to this population study of 30,000 people, so you're good. And I think that's a great area for intervention and looking at those ApoA proteins and lipoprotein A, looking at those heart attack proteins to say, well, it's as a distribution curve of people that are very much, right in the middle of having those apoproteins as sort of a baseline, kind of a normal, if you will. And there's people on either tail of that curve. Some people are just blessed with great apoproteins that vacuum up wayward cholesterol and take it to the liver no matter what they eat.
Mm-hmm.
And there's others that, are actually doing a lot of the right things, but and even if their actual lipid levels or VLDL or other things aren't high, which is kind of a certain familial condition people can have, they're 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 getting they're getting more cholesterol deposition in their arteries. It reminds me of a great cartoon in the New Yorker where a doctor's talking to a patient and he's got a lab result and he says, well, it looks like 40% of your cholesterol is good, 40 is bad, and 20 is undecided. So there's a lot of mitigating factor that changes, the way I'd put it to a person who's not as into this stuff as I am would say, well, there's things that can make that cholesterol more sticky and more of a menace.
Mm-hmm. Absolutely. I mean, I guess, since atherosclerosis is at the heart of all this and it's an inflammatory condition and disease, it would obviously seem like a good place to start to gather more information around having more biomarkers and data around arterial inflammation and potentially stability of plaques and things like that. And of course, this is where some of these more novel biomarkers that you write about and speak about quite frequently of inflammation that become more important. And maybe we can start the conversation here around C-reactive protein, which is one that's commonly run in a medical checkup. Acute phase protein released by the liver during inflammation. It's playing a unique role in the immune response. Can you talk a bit about CRP and its role here in as a marker of inflammation?
Yeah, CRP, C-reactive protein, it's very highly, associated, correlated with cardiovascular disease. So although it can be high because of other things, like maybe you have a dental abscess and it's causing this reactivity, it is really associated there. So for instance, the higher CRP level patients have been shown to have twice the mortality. If they have a heart attack, they're twice as likely to die. And just in terms of disease progression, CRP is a really good predictor of someone's possible progression. So, in other words, will somebody find themselves at a heart disease state more quickly? The plaquing that might happen is more likely, and it is getting some attention from internists and some cardiologists who order it along with the lipid panel. And I think some of that attention comes from the fact that in some of the larger trials, the statins, in particular rosuvastatin, which people know as Crestor, lowered CRP, and the more it lowered it, the patients that really got the lowering effect had fewer heart attacks as a group. So, but what's interesting at the same time is many cardiologists and internists don't order it at all. They like to have one target to hammer away at, and CRP is not it.
I mean, it's very interesting what you mentioned there around the statins, and is the effect actually coming more from an anti-inflammatory effect rather than a lipid lowering effect. Obviously, the LDL function is going to be there, but to what degree, in your opinion, would the statins, the effect on inflammation, be driving a lot of the potential benefits?
Oh, I think it's a big chunk of that. And I mean, certainly there's the lipid lowering aspect, but it's 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 like a blunt force type of inflammation lowering. And in the kind of work we do with people, there's so many other approaches to that. Um, there's so many other approaches to that in ways that you can help someone lower their own inflammatory levels. There's a third element. There's a third element to the statins, which is plaque physiology. And this is kind of a new line of research in statins, but it seems that statins cause plaques to actually tighten up and calcify a little bit.
Hmm.
So if they're not too far advanced, they become more of a bump in the road and less at risk of rupturing. So that shriveling up of plaques, not the point where they completely regress, but they go from being, you know, um, a pothole that's ready to explode to just a bump in the road. That is probably another part of their value that's just becoming understood.
Yeah, I mean it's fascinating, the different mechanisms at play. And if we talk about some other biomarkers that people might be less familiar with around, just as you mentioned, inflammation here. If we talk about arterial wall inflammation, lipoprotein-associated phospholipase A2, so PLA2. Can you talk a little bit about that biomarker? How frequently it's run and what it might be telling us.
This is telling us how much active inflammation, which includes scavenger cells attacking a plaque, is going on. So it's sometimes, called the plaque test. It's not measuring how thick the plaque is, it's measuring how stable the plaque is. And so this is really important because a plaque that ruptures is going to attract platelets, and platelets are the things that help you clot. I it's not serious, but I cut my arm. I cut my arm gardening yesterday. My 8-year-old son said it looked like I got attacked with a katana.
Nice.
Well, it's not that bad, but fortunately, my platelets came into the rescue and form a blood clot. That's usually a good thing. When it happens in, the right coronary artery and blocks blood flow, then it becomes a catastrophe. And so the plaque test, PA2, can show us, are those plaques on their road to rupturing? Because what they are in the middle is dead tissue, cholesterol, some dead white blood cells, and which can continue to gather LDL. But what's on the outside is like a dome that's made out of collagen, and eventually it stops looking like the normal lining of the artery that we had when we were all 3.
Mm-hmm.
It just starts to look like scar tissue. So as that scar tissue starts to become parchment thin, it's ripe and it's ready to rupture. And so the plaque test is immensely valuable to know, are you walking around with stable plaques that might follow you till you die at 101 having had a great life, or are you someone that has plaques that are ready to rupture?
Yeah, obviously, tremendous insight if one can get a little bit more information, more, stronger association with some of these biomarkers like that around, the obviously being able to measure these things with the inflammation and plaque vulnerability. And, myeloperoxidase is also something, another biomarker that gives us some insight around plaque vulnerability. Can you speak a little bit more about what it's measuring there, and does that provide us with more information on top of the LPLA, or is it a different type of information we're getting?
It is a different type of information. It's related. So if you could only pick one of the two, they'd both be pretty good at telling you that things, that you have a hot spot, that
Mm-hmm.
there's active inflammation, and that if you think about this plaque, growth in terms of velocity that you're at a high velocity. And MPO is basically looking at an enzyme that white blood cells make when they've become interested in the plaque, interested in the sense that chemotractant or chemical markers that attract them are pulling them into the fray, and they're essentially behaving as if there's an infection there. So they're getting involved with the plaque, putting out these strong free radical creating enzymes, and that inflammation begets more inflammation. It becomes what's called a positive feedback loop, which we don't really like to see in the body. It's a loop without a control system. And so MPO is showing you that those plaques are not just some elevated inflammation, but now are really actively hot, and you're in the fast lane. When I lived in Toronto, the 401 highway had the collectors in the express lane. Now you're in the express lane to having those arteries plaqued over.
Yeah, and I guess if we add to that metaphor, I mean, when the potholes get that deep and you're traveling that fast, I guess that's where bad things can happen, right?
That's right. That's where the wheels come off.
And so, some of these markers, obviously not traditionally run, but would, provide great insight. And I think, if we continue down this road and talk about, just the peroxidation of lipids, so, F2 isoprostanes, this is a measure of lipid peroxidation, and this is due to the metabolism of arachidonic acid. Now, can you talk a little bit about that in terms of insights?
Yes, that is. This is one of my favorites. Now, these prostanoids are essentially drivers of oxidative stress. And what's fascinating about the F2 series, there's two things about them. One is they're not dependent on an enzyme. Enzymes are proteins the body makes to catalyze chemical reactions. We make lots of prostanoid substances in our body. These F2 isoprostanes are created when a very common fatty acid in the body called arachidonic acid is exposed to a lot of oxidative stress. And the other really great thing about the F2 series is that it's specific to the artery. So it's showing us that essentially the byproduct or the footprint of a lot of oxidative stress in the artery is occurring. And this is tremendously important, one, to help people with lifestyle education. The other, to show someone that, well, you could go for an angiogram tomorrow and they're going to find that your arteries are all completely clear, but you have a lot of oxidative stress going on, which is the beginning of aging, and begins to change or transform the lining of the artery into something that it's not supposed to be.
And how does environment impact that story when we talk about, arachidonic acid and its role in building muscle? And if we have we talked about body mass index previously. So if we have an individual who has a high amount of lean mass, low body fat percentage, blood glucose controls, terrific, aerobic fitness, that type of scenario versus, an environment where another individual might be, overweight or obese. Unfortunately, the typical, as you mentioned, 2/3 of the population being overweight or obese, abdominal circumference, above 38, 40 inches. So, let's say up towards 48 or 50 maybe. So significant abdominal adiposity. How does that then start to change how, the expression of some of these, of a marker like that and what it might be telling us? Is it the same in each individual, or would that be more pronounced in a more pro-inflammatory milieu in an overweight, obese individual?
It would, and you've hit on a critical aspect here. One I find fascinating, the people, even young, asymptomatic, apparently healthy adults that have the highest F2 isoprostane levels, and not ridiculously high, like just the higher 10% of readings. I think it's over 130 picomoles or some tiny, little measurement like that, have a 30 times greater chance of developing metabolic syndrome.
Wow.
30 greater times.
Wow.
So there's something going on there with that, you know, lack of movement, deposition of visceral fat, belly fat, visceral fat as well around the
Hmm.
organs, and you know, inflammatory loops going on in the body. So it's really like an early warning system to me, this particular test.
And later in this conversation, we're going to talk a little bit about strategies. But as you mentioned previously, some of these biomarkers, when we do have clients who we can see are at risk and need to be making some changes, but some of the conventional markers, which are great for kind of longer term prediction, but you know, I'm thinking a lot of men's health here and dealing with men who are 40s, 50s, 60s who, sort of might be able to convince themselves that they don't need to start making changes because, the conventional markers are good enough, let's say, to be able to continue with their current lifestyle, nutrition, exercise. So, I imagine you, in terms of running some of these biomarkers, this is providing us with that insight to be able to start to leverage some change, right?
Yes, it serves as something measurable for someone, a wake up call, and something that can be retested to see, well, hey, I'm eating fewer burnt foods and fewer deep fried foods, and giving my body that experience of getting my heart rate up and sweating and exercising and eating more plant foods. And look, this measurement went down. I have less of this oxidative attack going on, that's transforming my arteries into arteries that are going to get really good at collecting LDL. So it's a great educational tool for people, and who doesn't get motivated by some kind of result they can see. So it's great that way.
100%. And before we dive further into maybe some of those strategies, oxidized LDL, another biomarker of inflammation and one that we see being run, more commonly in conventional settings. Can you explain to listeners, what are we measuring here with oxidized LDL, and what are some of the associations when levels do get higher with the oxidized LDL?
Well, oxidized LDL is uh, LDL particle, which is a big lump of fatty acids, triglycerides, and certain proteins. It's it's basically you know a way of moving fats around and cholesterol around the body,
Mm-hmm.
which are important for synthesizing normal tissues. You couldn't live
you
without it.
need you need it, right?
You need it. You needed to have a brain. You needed to have a spinal cord. You
Immune
needed to have
system, yeah.
muscles. Which is another aspect of this is to do you really want to drive that into super low levels, but you need it. And so this particle is sort of like the Amazon delivery truck of these cholesterol fat molecules, and it has certain proteins on it, and these can get oxidized. So can the actual fatty acids too, but the proteins in this particle are like almost like the delivery information for the order. So they help the particle interact with tissues where this fatty and cholesterol material can get delivered where it's needed and not get stuck somewhere where it isn't needed. Now, when that's oxidized, which can happen in these very inflamed arteries, um, that particle is just more likely to crash into the lining of the artery and essentially insinuate itself into that lining of the artery, which just feeds the whole process because then certain white blood cells come along to try to scavenge it, and they just get sucked in and die, and you have a plaque, that continues to grow. So, and that is why it's great to see more of that getting ordered by more people in healthcare because, you know, oxidized LDL is far more dangerous, far more atherogenic than plain old LDL. Just as there's other parameters of LDL that can make it more of a threat. But It's a simple one. It's just showing the LDL got oxidized, which made it, more of a menace, but a very important one.
Yeah, I mean, when we look at some of the associations around increased levels of oxidized LDL, 4 times more likely to develop metabolic syndrome. In healthy middle-aged men, high oxidized LDL, again, 4 times greater risk of developing coronary heart disease. And of course, as you well know, increasing in a stepwise fashion with severity. So, terrific marker to be getting some clear information on potential risk. And of course, then saying, okay, well, what are we going to do about this? And so when we talk strategies here, diet, movement, lifestyle, what are some of your, fundamentals or pillars or things that you are saying repeatedly to clients when it's time to do something about these markers when they are out of balance?
Well, I always start with diet, and um, this is extremely important in several ways. One is diet is the place where we're going to ingest and absorb, hopefully absorb the things that are going to build healthy tissue. So our plant-based antioxidants, our vitamin C, our proteins. The other aspects of diet, though, are really significant too, in that, diet can modulate inflammation. It can work in our favor. So, we see, sort of processed food diets leading to obesity and ramping up inflammation, it would appear. And then things like the Mediterranean diet over the long term, not doing that. Um, so you've got those two things going on. I guess the third thing, and it ties in with inflammation, but it's significant, is really really atherogenic aspects. So the one I like to pick on a lot, and I've been telling people for 25 years to go and eat good oils. If we take vegetable oil that's used in frying operations, or even just a lot of the store-bought cheapo vegetable oils,
Mm-hmm.
those have been so processed and extracted with solvents and heat treated, bleached, deodorized. They're they're more inflammatory. Um, they're more inflammatory than saturated fat for a lot of people, and so getting people on the right diet, it helps build their body from the cell up. It certainly can impact their inflammation, and it gets them away from things that are literally killing them.
Yeah, I mean, very well said in terms of just that real 30,000 foot view of processed versus non-processed. I mean, it's incredible that, North America, Canada, the US, the UK, more than 50% of everything we buy is ultra processed food, and the caloric density that brings on board, and leading into, higher blood glucose levels, and of course things like weight gain. So, in terms of dietary strategies, then, you mentioned a couple. I mean, as one of those sort of principles of getting people to lose weight and improve that inflammatory terrain is simply weight loss, simply achieving a bit of a caloric deficit. Is that something where, if your client who, let's say they are overweight or obese, if they're starting to lose weight and you're seeing improvements, do you have a preference over different dietary strategies, or would that simply be a good first place for people to be moving?
No, I like in a general way the Mediterranean diet, not only because of the evidence, but because it's very time tested.
Mm-hmm.
Um, and for people that are not as into the olive oil and other things like that, or as many Solanaceae products like tomatoes and chilies,
Mm-hmm.
um, there's like Scandinavian variant of that. If you're more into root vegetables, and you know, and that for people that are doing that and maybe a little less fish, we're steering them toward grass raised, grass finished meats
Mm-hmm.
and things like that, or Arctic wild caught. I worry a bit about the sustainability, but wild caught fishes that have the high omega threes. So I like that as a baseline. I've found over time, um, eating is such an ingrained behavior. Even though great changes are possible, um, when someone can kind of start with some foods that they already know or concepts that they already know, like, well, you know, I like pasta, and I like roasted or charred vegetables, and I like salad, and yeah, I could eat extra virgin olive oil. There's some familiarity there. Having said that, there's other shoes that fit other people here, and um, um, one person I'm advising right now, he's doing essentially a form of modified fasting, and he's a very big person, 6'2", and very big framed guy, but he's lost about 85 pounds just by, doing, um, a ketogenic approach.
Hmm.
Now, he's very robust and got a very big constitution, and he's got a lot of reasons to lose the weight, including for his knees and his mobility. That would be too drastic for some people. Maybe they're working two jobs, they have little kids at home. The um, the mood swings and just the detoxification and doing that is just it's going to backfire on them. Sometimes you don't really know until you try, but for them, things like a 5 and 2 approach where they can eat healthy 5 days a week, and then 2 days a week they're sticking to 500 calories, which can be pretty interesting if you make it that way. But they're hungry, they're dreaming about pepperoni at night and
Yeah.
everything like that, and can't wait to get up and have breakfast. But that type of approach as well can work for people. Typically with weight loss, activity levels are important, but at some point the energy balance has to shift, and that means taking less in.
Yeah, it is. Like you said, it's amazing that obviously compliance is such a, the best predictor really of weight loss. And so finding that diet that clients do gravitate to or find some enjoyment in is so key. And I always find it funny as well when you go to Italy, the size of the pasta portions is a lot smaller than if I go back to Canada or the US, right? So something got lost in translation with portion sizes there as well, which is important for us to reinforce. But you talked, if I shift gears, so you talk movement, and of course, exercise. How much can exercise move the needle here if we have clients who are at increased risk of cardiovascular disease?
Oh, I think it's extremely, extremely important. Um, and there's different levels of that. Human movement is such a fascinating area. And so the one a lot of people think about is, well, I'll get my heart rate up and not only burn more calories, but I'll strengthen my heart. And that's, of course, absolutely true. Um, you know, um, my father had, and he survived it, but he had a massive heart attack at 51. And at that time, they didn't understand these issues very well. A few years later, he was taking things like ginkgo biloba and CoQ10. He had a son in naturopathic medical school,
Nice.
but he worked a very demanding physical job all day, and then would go to an Olympic-sized swimming pool at 4:30 after every afternoon and swim 30 lengths. So he probably survived that heart attack because he had great collateral circulation and just a lot of muscle in that heart. He'd played sports a lot as a kid, and so he'd been doing that for half a century, and that's probably why he survived. I speculate that if he'd been a bookkeeper or something, he probably wouldn't have made it. So um, there's that aspect, but movement does a lot of other things too. There's a lot of inputs into our nervous system um, when we move that really helps us a lot with stress, really helps us a lot with self-confidence. Our nervous system seems to depend Our brain seems to depend on that sensory information that comes to it in order to be adequately activated and adequately stimulated. And a lot of that comes from moving. And I tell people, obviously, an exercise regimen that challenges you in some way is really important to have. But at the very least, get out and move, take up something, do some yoga, walk, swing your arms, because we actually need that. Our brain is recording that, and actually starts to lose a lot of its integration when we don't have that sensory information from gravity, from contacting the ground, from our joints moving through space. Now, when it comes to the heart, I think a lot of good exercise also causes our overall circulation to open up into our muscles, and the heart doesn't just sit there like a mechanical pump by itself. It's connected to a vast network, some of it muscular, that moves an entire fluid system around using kinetic energy. And when we open up our muscles, that system gets moved and purged. Toxins can come out and go into something called our lymph, which is one way to dispose of it. Tissues are given that life-giving flow of blood, kind of like a sponge, getting wet and then wrung out. And so one of the lethal things that we do in our society, and this is becoming talked about a lot, is just the amount of sitting, the lack of movement.
Hmm.
That's my former Pilates teacher and therapist. Some years ago, she had done her master's in movement therapy and spent, I don't know, a month or two with the Maasai people in southern
Nice.
Africa. And even the septuagenarians would walk 15 miles a day.
Nice.
So,
Use it or lose it,
you know,
right?
exactly. So we're living a most unnormal life, I guess, some of us in the sense of not moving. But I think that is extremely important. And I just speculate here, but I think we will find out in years to come that lack of movement causes, um, more inflammation and something proatherogenic in the heart. Like you say, use it or lose it. Like if we're not making those demands on our cardiovascular system, it, you know, just starts to act as a repository for cholesterol. So that, that will, I think, continue to be seen as a very serious thing.
I mean, I love the metaphor with the sponge as well. I mean, that's such a great, being able to fill it and then squeeze it out. And, that's what movement's doing for us. It's incredible to just be able to try to find a place to integrate that into one's day is can be pretty powerful. And just as you mentioned, even small bouts of, Martin Gabala's great work down there at McMaster University, even 1 20-second bout of intensity, going up a flight of stairs or carrying the heavy bags back still has significant benefits. So definitely folks need to find time for that and build their way up. And, we've talked nutrition, we've talked exercise. What about on the lifestyle side of things? The two that tend to jump out are around, sleep or lack thereof, if we're being more specific, or around stress. What roles do these play? Are they more influencing the nutrition and exercise, or in and of themselves are they contributing to this potential risk as well?
Oh, in a big way, sleep is not met typically. The American Sleep Institute estimates, at least here, and it's probably similar in the UK or Canada,
Mm-hmm.
uh, about 6.5 hours of sleep. And that was before Netflix. I think they did
It's
that
going to be
research.
going down, I think.
Maybe it's six now. And really, a lot of people, I think at least a third of the population needs closer to 8. Another third can do okay with 7. So we're sleep deprived, and that raises our cortisol levels, which increases inflammation. Um, it gives us less opportunity for that deep sleep when our body repairs itself. And that, repairs, involves growth hormone secretion, which really comes out in the deeper, you don't have to be dreaming, but in the deeper stages of sleep. And so without growth hormone, we can't maintain as much lean body mass. We don't do as good a job, you know, repairing out with the old and with the new. And so that's a great way to age on the outside and the inside, is to sleep deplete yourself. And stress is similar. It cranks up our cortisol levels, and stress stress seems to stress seems to you know dysregulate our autonomic nervous system, and that are, that is the branch of the nervous system that controls all of our organ functions. And it seems like with stress, we get like a lack of coordination in the way our nervous system controls all of those organs, our heart, but our lungs, our digestion, our liver, our urinary system. And we don't always think of that. We think of stress as causing a pain in the neck or palpitations
Hmm.
or maybe some bowel cramps, and that's all true. But actually, stress can really, everything from atrial fibrillations to, you know, um, you know, decrease in digestion and things like that can be a big problem. So um, it's not having a little that's too much of the problem, but that pervasive stress. And unfortunately, sadly, a lot of people are going through more of that right now, not only with the at home or you know, if they have a loved one that's struggling with COVID-19, but just the economic issues right now where people are out of work, that kind of stress where someone can't escape and they can't do anything about it, that is one of the big factors in raising blood pressure, raising cardiovascular disease.
Yeah, it's incredible, isn't it? How, acute doses of stress, such as a form of exercise, do wonderful things for all these systems. And then when it becomes, more chronic and persistent and even low grade, but just always there, it starts to really unravel our health, the nervous system. As you mentioned, even the impact on cognition and emotional health, and how that then trickles down into how we eat, move, and can't sleep and all that. So it is a pretty intricate web. And I want to respect your time here, Doc. Obviously, on this topic of cardiovascular disease and some of these novel biomarkers, if we look at the evolution of research in this area, where do you see things going in the next 5 or 10 years?
I'd like to see more outcome study around this. We just had a paper accepted for publication here where we took a group of patients and looked at what therapies they had been given because it was a diverse group of practitioners, and we're really seeing a big spread in the type of therapies that naturopathic doctors do. So and we have plans for this, and others are doing it. Really like to see what type of things, what type of exercise and diet, and some supplements impact myeloperoxidase, isoprostanes, and we on our end, and see what of all the many things we can do for people, what brings down that inflammation the most in terms of the broader healthcare sense. Um, I would love to see you know a strongly resourced institution like a Harvard, in collaboration with some of our naturopathic colleges and others, um, do a big study like a 15,000 person study to really see now, you know, what is the change in cardiovascular mortality with, knocking down myeloperoxidase vastly for someone in their 40s. A lot of that is already out there though. So I guess, my big dream is to see it more integrated into practice for people. But I think the obstacle is, medicine has been wildly successful on many levels with this. I mean, cardiovascular death has gone down in the last few years, but they'd like to have one target and hammer away at it. Um, so that would be great to see, is more research into naturopathic protocols and more adoption in the generalized healthcare setting.
Yeah, I mean, it definitely seems like it's a timely subject with, as we mentioned, the population becoming more and more unhealthy and overweight. This is going to be, important for having earlier markers and ways to be able to, inspire, motivate, and build some habits around nutrition and movement and lifestyle. So really appreciate you carving out some time today, Doc. If people want to keep up with your research and some of the work you're doing, where's the best place for them to do so?
Well, a good place to be would be to contact me um, at fsmith, F as in Fraser, Smith, no dots, all under lowercase, at NUHS.edu. I'm involved in several different organizations, but they can feel free to reach out to me. Also, for your athletes, it's good for them to check with someone like yourself. And I did want to throw that in. Sometimes the myeloperoxidase or F2 isoprostanes can be a little bit high because they're using their mitochondria so much.
Mm-hmm.
Their metabolic furnace is higher. But for those athletes eating a good amount of plant foods, they're not at higher risk for heart disease. They're going to have super strong hearts, well perfused vasculature. But that's why it's great to talk to someone sometimes, because we can be surprised by these tests.
Absolutely. And is that something you'd expect to return to baseline if there was an off-season or post-career type thing?
Yes.
Fantastic. Well, listen, again, really appreciate the time. This is such a fascinating topic, and look forward to keeping up with all your tremendous work, Doc.